make a start. So welcome to the attendees to this clinical webinar this evening. We have some, yes, illustrious presenters from Germany who are going to run through a project in Germany called MII, the Medical Informatics Initiative, which was in some ways the precursor, in some ways, to Germany joining and becoming a member of SNOMED International.
Door opener.
The door opener, indeed. The one thing I will just do, if I can share my, okay, oh, I'll do this at the end, that's fine. Okay, so without further ado, I'm going to hand over to Martin or Sylvia. Martin's the first one, isn't it? I'm going to hand over to Martin to start, followed by Sylvia and then Cora. So Martin, I'll hand over to you.
Yeah, I think Sylvia will yes, open the presentation.
Martin, it's your turn.
As you can hear, the sound quality is quite. Yes, I just started. Do you understand me? Because sound quality might be very bad because I'm on a train, but so I try to give this talk. I think we will introduce ourselves, but we are all members of the Medical Informatics Initiative. Sylvia and Joseph and I work in different working groups and providing this interoperability platform. And I'm from the University of the Technical University of Munich. Next slide.
And Martin, it's a little bit noisy, so should we wait a second?
I cannot.
I
think this is just.
Because your train stopped at this moment, and maybe we make 2 slides and then you carry on. Oh no, it's ready.
It's okay now.
It's better.
Yeah, so
yeah.
What we see is like the processes and
or maybe he disappeared.
Okay, so I take over.
Yeah.
Yeah, it's yeah.
I think that might be
Germany. Okay, so okay.
Still there?
No,
no,
I think he's away. So we will just present to you the results of our Medical Informatics Initiative in Germany. And this initiative tries to exchange data within our university network. And this network has 34 university hospitals. And our data exchange is based on several use cases. So, and there are many challenges. So how can we achieve harmonized data structures? How can we define consistent and broad consent and governance policies? How can we objectively measure and optimize data quality? And how can we securely implement data sharing? So therefore, we built a collaborative solution through the medical informatics working groups, which are connected to each other. And here you see our working groups Thomas and me, we are the chairs of the interoperability working group, but we have another working group that deals with the consent, which is based on FHIR, and a data sharing working group for secure data sharing methods. And they all work together. We defined consent templates and harmonized policies and the core data set. And we will talk about the core data set in a minute and the implementation of all these things. So first of all, we we worked on many legal aspects like consent, harmonized data policy, and data sharing process models. And the consent is based on the, I don't know if you know the IHE, the integrating the healthcare enterprise BPPC and APPC specification, and is then specified in FHIR with the consent resource. And there we use the HL7 vocabulary. Like vocabulary like deny or permit or security labels for the consent. And as you all know, there's a vocabulary within the HL7 group, and right now they don't use SNOMED. Hopefully this will change. So what terminologies and standards did we use? First of all, we tried to find the same way that the European Commission is going, like they have a standards roadmap, and we have a national strategy towards FHIR and towards terminologies that are already in use, like the ICD-10 or the OPS, the procedure classifications, or the ATC for ingredients. And beside that, quite new for us is SNOMED, because we are SNOMED members since a few months. And we are a law country since, I think, I met Clem McDonald in Cologne. I think it's 50 years ago. So our government chose law for lab results and vital parameters. But it was not implemented by the software vendors because there were no penalties not to do it or something. So here you see our standard words within Germany, and we used it for the Medical Informatics Initiative for scientific purposes as well. So here you can see the core data set, and it is modeled in a tool that is called ArcticCore. But first of all, we had to find how we can use the terminologies within our basic models and the extension models. And perhaps you remember the European project EPSOS and the European project Accessity, where we did an assessment for Europe, which terminologies we should use, and especially on SNOMED CT. So it was quite nice and easy for us to use SNOMED CT here in these basic models, because we had already some experts here like Martin and Josef or Cora in Germany who knew how to work with these terminologies. So here you can see our data structure, which is based on HL7 FHIR. We have a semantic annotation within our modules, and we work with common tools like ArcticCore, which is built within the HL7 community to connect the CDA, especially HL7 CDA, with terminologies. And right now, the newest development is that ArcticCore supports FHIR as well, and simply FHIR, where we try to have an archive for all implementation guides. So there are many more coming. And here you can see our modeling tool, and within ArcticCore, we can see other models from other countries, like from Austria, the ELGA, or other projects. And here you can see how we use SNOMED CT. First of all, we didn't translate the concepts, but we made a mapping to the ICD-10. And we are using different codes for different terminologies for different use cases, but we harmonize them, and we find mappings to other coding systems as well, like ATC or ATC to SNOMED or OPS to SNOMED. Yeah, this was ArcticCore, and after that we do the modeling and the profiling within the Forge and Simplifier, and we can use open source tools as well, like Fish and Sushi, and codes and value set, as you can see here, can be binded, translated, and constrained with different cardinalities and binding strengths. So data can then made available directly at the source, like at the list. So you can have LOIN codes or SNOMED codes here at the list side or PDMS side. This is for intensive care, for instance, and or later on. And then we have a standardized manner how we use the harmonized data pipeline. It's called ETL, it's the extract, transform, and load process, where we annotate concepts with codes and file resources, and harmonized data is available, can be queried and joined, and it can be queried and research, joint research is possible. So we were using identical data for the use cases, and here you can see our use cases within the 4 consortia, and from the very starting point from our medical informatics initiative, we were using these core data sets. So the core data set modules can be used across the consortia, and the use cases, for instance, lab results, conditions, or medications. And then the pandemic came. We developed the GECKO, and this is the so-called German Corona Consensus data set within the German COVID-19 research network of university medicine based on the core data set. So we already had the core data set, and then we just only had to develop a more precise standard. And it is a compact standard of standardized data elements to be collected in COVID-19 studies. So how did we use SNOMED here within the GECKO data set? Well, we had 31 out of 61 value sets who uses SNOMED CT, and we had to find new SNOMED codes or so-called extensions. That's here, the NUM or CDC or LOINC combination of SNOMED. And so we had the chance to have a very precise data set for COVID-19 research. And here you can see a REDCap form, REDCap export to FHIR via REDCap export to FHIR, sorry. And the same with other vendors like SecureTrial, that is a vendor from Germany and a local vendor, and they made interfaces to the FHIR standard out of their ECRF. So we used many concepts, and most of them were pre-coordinated, and most of them were from the root concepts: disorder, clinical finding. So, and the most important point is that we harmonize all the important projects in Germany, which are based on the International Patient Summary that you possibly know. You have the global patient set provided for the IPS, and you see the IPS and the core data set, and these are used within other applications like the EHR from Germany, it's called EPA, or within the lab result infectious disease communication from our Robert Koch Institute, or within our detailed clinical models for the immunization report, for instance. Okay, now I hand over to Joseph.
Okay. Yes, maybe a short introduction. Yes, Joseph Ingenev, I'm coming from the north of Germany, from Lübeck, and I must say I dealt quite many years with SNOMED, so it's very nice to have the opportunity to tell something about I must admit, about a very local view on that, what we are doing in our location as one member of the Medical Informatics Initiative. So it's a focus on that. And I have numbered 4 issues that, from my point of view, have to do with SNOMED and has to do something with making profit from SNOMED and using it. And the first one is the Miracum use case. Miracum is one consortium. I'll tell a little bit later, very shortly, and it has to do with molecular tumor board. It's a use case. It's quite interesting. The next one is a HiMag use case, infectiology. I come on it later, where we develop with other partners this smart infection control system. And the third topic is a Feasibility Explorer for querying all the data, federative querying all the data in the remote 20 or 30 data integration centers and getting all the data out of the databases by using, and that is what I think is very important, all 3 little projects by using terminology server, because without a server, we have to look into books or into Excel sheets, and that's not a very good idea. And providing this server for medical informatics researchers is, if you want, a fourth topic having to do with SNOMED. So that's the starting picture. Coming to the first point, this Miracum use case deals with molecular tumor board, as I said, and our site, UK University Clinic in Schleswig-Holstein, Campus Lübeck, it's called UKSH. We are actually a member of the HiMag consortia. So this is a cross-consortia use case. Yes, we working on the interface between both consortia. And most important, this use case uses cBioportal. You might know cBioportal for cancer genomics. I added this link as a central platform for visualizing and analyzing this genetic and clinical data. And this makes heavily use of a little terminology called OncoTree. Here's also a link. I don't click on the link. You can click on the link and see this very smart OncoTree terminology or classification. In fact, it's a classification. It's a small one, which especially for oncology is established for many years. But our routine data, that is based on ICDO. We have just ICDO location and histology codes and nothing else. So what do we need? We need a mapping from ICDO couple codes to OncoTree. And we use SNOMED CT for mediation. And I show it with this picture. What we do is we have these both codes and map firstly on this first level simply from ICDO location to SNOMED topography, and from ICDO histology to SNOMED CT morphology. And we can then try to find pre-coordinate codes, but if you have 1,000 locations and 1,000 morphologies, you have 1 million combinations, and there are only, let's say, 50,000 SNOMED oncology disorders. So it's just not enough. So it's a very good idea to go directly on post coordination and do it from the other side as well. Mapping the OncoTree codes in post coordinate SNOMED disorder or disease concepts. And then after then, it's just a question of subsumption. And we can make this interface by subsumption. And here's an example. And I don't will proceed too much, but it's heavily important to have one more. Can you click one more? It's heavily important to have this link to Onserver. So we had a very sophisticated use case to test post-coordinated SNOMED concepts with post-coordinated SNOMED caps concepts, thousands of them. And that could be handled by Onserver quite well. And we will have one click more, and we will have soon a publication about that. I can tell a lot of things more, but it's enough for now. It's just an impression that we work on such a topic, making heavily use of SNOMED and sophisticated SNOMED. I think it's a very good idea to do it in other mapping initiatives in a similar way. So the second little project is HiMag. We had already a talk from Semmler, Gansland, Sachs on the SNOMED Expo last year, so I don't want to go into detail too much because it's already reported last year. And I just show this microbiology report that is modeled within OpenEHR with the clinical knowledge manager. You see the microbiological report here on the left, and next click. Then mostly important is this pathogens on the bottom, where we get lists with thousands of organisms from SNOMED. That is something that Cora Drenkhahn, she's also here in this session, did with colleagues. And at the end, this final SMIX tool can exploit this very specific coded organisms and other related stuff to make analysis of outbreaks and so on. So you can look in the last year, again, some publications. We dealt with SNOMED and Doink and went into more detail, but not now. Okay. The next one is very short. Sorry for that, but I just wanted to mention this activities that is still work in progress that are going on with this Feasibility Explorer. It's a query component that supports federative queries, and that can be directly used also for checking eligibility criteria of clinical trials to get patients that fulfills the inclusion and exclusion criteria of studies and to find them. But the challenge is to have a good query interfaces with pickup lists for queryable criteria. And again, it's dependent on a link to the Onserver. From that, you get all the simple and more complicated criteria, sex and status and laterality and disorder, whatever. And for especially for the hierarchical value sets, it's a little bit more complicated to get it in a way that users can handle the input of criteria and then ask federatively all the sites for data that fulfills the query. Yes, that may be enough, but again, my thing is that again, the infrastructure must be in place, otherwise you cannot work. And so the last one is the Onserver issue. We are using Onserver for a couple of years. In Cologne, it's administrated, and in Lübeck, we put all the content on it, and Sylvia is also in the team to get the value sets and the code systems and the mappings right. But providing and managing such an Onserver is not so easy. You have to provide different formats, you know, of different code systems. And yes, on the other side, the API works. You get all these fire operations you see on the right, and we are very satisfied. One point that I want to come a little bit is this syndication issue. You can click. Oh, this is just the workshop. You can have a look. On the beginning of this month, we had a big workshop to tell all the participants what's going on, what tools we are using, how they can make profit of terminology services for validating codes and for all the stuff you need if you are a software developer and want to use the codes that Sylvia put into all the specifications. So it must work for the software developers. So click. So then just click once more. Then it just, I repeat that what Sylvia already told, and you can click one more and a last one. It's just telling that we go to the simplifiers, get the specifications of the Gecko and the core data sets, and we automatically pull all the value sets and code systems that are referenced onto the Onserver in order to have standardized data entry, in order to have validation, in order to do the data queries I told earlier, and do data analysis. That is just a slide to repeat this basic arguments for a good terminology server. And I can nearly come to an end. Yes, the server, and go one more. I have to look myself. That is from the company Onserver. We can skip that. That are the arguments to use this indication. And the last slide on the next one, I can add some few words. It's my last slide. And for my impression, we need something, I think in every nations, but also in Germany, that is called Cascaded terminology servers. We cannot have only just terminology server in this gray box with Gecko and core data sets for two initiatives that work very close together, but we need some more. We need a national one for the official classifications and terminologies by BfArM, for example. We need for the governmental activities one. We can go one level deeper in the consortia. They can add their use case terminologies. Maybe it's a little bit too many, but maybe also on the local sites, you need the opportunity to add your very local terminologies, but all are synchronized in a hierarchical manner. And I think that's very interesting to think about this architecture and to speak with other responsible persons in other areas, how we can decide on a national level about this, from my point of view, very necessary infrastructure. So I'm ready.
So, thank you. This is our link to our initiative in the German and English language for all of you, if you're interested.
Are there any questions?
So thank you. Thank you for the presentation. That was really good. So to the attendees, you obviously, so you haven't used Zoom webinar before, you don't get the opportunity to speak. So if you have questions, please put them in the Q&A box.
Yes.
So I'll look to my colleague, to Charles. Do you have any questions, Charles?
So I am allowed to speak, eh?
Oh, you're allowed to speak.
Yes, I think one of my questions, I guess, is how is the core information generated in this network of 34 hospitals? Is that by clinicians working with patients and recording SNOMED concepts in electronic health records, or is the use of SNOMED a post-clinical event? That wasn't clear to me.
It's more post-clinical,
Right.
and the persons who were responsible for the core data set for the specification were clinicians as well as medical informaticians, and everything was based on the international patient summary. And you know the patient summary, we were like in EPSOS. I think you were in EPSOS too.
We were once upon a time, yeah.
And so everything was based on the international patient summary, and within the EPSOS project, we had many clinicians as well. So
I would add, it's a little bit, as Sylvia said, research-related motivation. And what you asked, you're right. It would be much more nice if all the clinicians in the clinics, in the early stages, are involved by data entry, by caring patients, and so on and so on. But I think in almost all countries, it's so difficult to get SNOMED to that stage. I think we need another 10, 20 years because the systems that are used in real hospitals, in doctor's office, have a little bit to change, and it needs time.
Yeah.
But Charles, there's a new era going on right now because our specifications for our child care plan, for instance, or for our immunization record, this is based on FIRE with SNOMED and other terminologies, and you have these value sets or F sets that they use, and they don't know that they use, and they're behind in the system. There's a SNOMED, and they don't even know that there's SNOMED within the system. So more or less, I think in 1 or 2 years, Joseph, they will use it in the first place.
I must admit, fortunately, something is changing. I do it 25 years, and for 20 years nothing changed. But really, for 1, 2, 3 years, things are changing, and especially on the governmental level, that's important. On the governmental level, actually, there are some initiatives why I'm optimistic. Because there must be some kind of, how do I call it? Some kind of duties, or some kind of, not penalties, but there must some kind of force that there are incentives. You should do it otherwise. Because just to say it would be happy if you would, nothing changes.
This is slightly going off tangent, but I'm assuming that in Germany the payment mechanisms are based on coded data, but that's never SNOMED. That's always either ICD-10 GM or some other coding system. Is that correct?
That's correct. But I think that the insurance companies are very interested in using SNOMED to have a more precise reimbursement system.
Yeah. Because I think in England and perhaps the UK generally, one of our greatest successes in getting frontline use of SNOMED has been in primary care, and one of the strongest drivers, actually 20 years ago, before really SNOMED existed in its current form, was the payment of GPs, general practitioners, for what's called the quality outcome framework, where you had to demonstrate that you had reviewed, patients with diabetes and inspected their eyes or looked at their feet and so on. And that was all coded using READ originally, and now SNOMED. And that was a powerful, I think, driver of that change.
Yeah.
Can I ask one more question about, because I know there are some in the chat line now, but one more question about the kind of how the data started. So in one of your slides, you show the creation of post-coordinated expressions to fill the gap between pre-coordinated expressions in cancer and then more complex ones, which you deal with by subsumption and use of Onserver. Again, is the creation of the post-coordinated expressions, is that sort of knowledgeable clinical informaticians, or is it you, or who wrote the post-coordinated expressions?
There we have an interdisciplinary team. We have medical doctors and informaticians. It's quite an interdisciplinary team, and we are close to the tumor documentation department. And we are close. We are discussing that with them.
And so the use of Onserver is to check their semantic correct, that they're semantically correct. Is that right?
No, the OncoTree is quite generic codes.
Yeah.
And the ICDO combinations are much more detailed. And the subsumption test solves the problem if I can map this one to this one by subsumption. And the interesting thing is, it's maybe a little bit theoretically challenges, but I could show a conference site from SNOMED themselves that there is a trade-off, sometimes a trade-off between logical subsumption and clinical thinking. For example, the bronchitis, how do you call it?
Bronchitis, yeah.
And the anatomy is called bronchion.
Bronchus, yes.
Bronchus.
Yeah.
And
Yeah.
bronchus is not subsumed by lungs. No, not subsumed. But in oncotree, all the neoplasms at the bronch ducts are within the lung.
Yeah, yeah, yeah.
So subclasses of the lung neoplasms. So
Yeah.
such kind of conflicts is quite interesting.
Yes, yeah. I better let Ian address some of the questions in the chat line.
Yes.
So one of the first questions, which is one which is close to my heart because I used to deal with some of this in the UK. So really around the patient privacy regulations in Germany, do they, I don't know, provide or cause significant limitations to what you can do with the data and who can access it? Is it a problem, essentially?
No, it's a challenge. We live with the GDPR like all European countries, and so but some counties like Länder to try to interpret the data's the GDPR differently. So we still have the problem that we don't have one core
Interpretation, yes.
who is, or one coordinator or somebody who is just responsible for all German questions, and so we have to ask 16 responsible people, and they have not the same.
But Silvia, that is something where in the Medical Informatics Initiative, especially that point, they made a lot of progress because they got all the 16 federate states on one table and they try to agree, and we have one national, for example, broad consent. So that is a success. And this consent is a way to get allowance from the patients to use their data for ... And that is a way we try to work in accordance to privacy issues.
But this was only about the consent and not about all these other questions we still are having in Germany. Yeah. It's very hard. It's a good question, yeah.
Okay, so one of the things which we're focusing on within SNOMED International, so we have a group looking at cancer synoptic reporting specifically. Do you use effectively synoptic reports or templates really for synoptic reports and use the data, bearing in mind that a lot of that data is free text, not coded data? Do you use that as part of the initiative, or is that just too hard?
So we are on our way. First of all, we have to specify it within CDA or within FIRE right now. And so we have kind of more or less like documents, and we are working together with our scientific organizations, for instance, for the pathology report. And so we try to have or to find structure that works in Germany. But still, if we have a structure and we are close to the end, so you can have a look at simplified our pathology report if you like, you still have to work together with the vendors, and the vendors, they don't really want to have these specifications because they have their own idea how to give their customers software and their templates, and not HL7 based templates. And beside that, they are not used to work with SNOMED yet, but we are very close we are working very close with the pathology organization, the German pathologists, who work with SNOMED since many years, and they really badly want to work with SNOMED because SNOMED is so close to pathology still, and it is really good for even for special cases like a prostate cancer and so on. So we are very close to having really good solutions, but still we need the vendors. So they have to be forced to do it, as Joseph already said.
Yeah. So moving on then. So there is a belief. I'll ask the question, but I won't give you my comment at the moment. There is a belief that SNOMED coding requires a lot of mapping activities in hospitals. So how do you make the case and convince the hospital to make that investment? And if they make that investment to actually do SNOMED coding within the hospital, how can it be sustainably funded?
So right now they get money from the government side.
That's what it's good.
And hospitals don't do this work, just university hospitals.
Okay.
But I think Joseph can say something about this because he is in charge of it.
Yeah, I don't want to answer this question. Yes, it's exactly the important question. It has to do with how much worse is semantic interoperability. If it's not interoperable, if I have free text, my insurance company gives money anyway. So it's really a special time now, whether it changes or not. It will change. I think it must change. Otherwise, all the artificial intelligence projects, all the deep learning fantasies will never work with shit in, shit out. It will never work in Minecraft. You can do deep learning with images, with speech, with all the subsymbol data, but astonishingly not with semantic data, with structured data, with drugs, with disorders and whatever. So that's typical at the moment, a critical, interesting time, whether people understand that the data quality is the most important issue. And whether somebody is able to pay for it, yes, interesting question. Well, important question.
I think it's an interesting question.
And not only the money, but also the people.
Yes.
It's also the people. You must get informaticians, also medical young people, to get them, to fascinate them for this kind of work.
So we had a clinical webinar last year from Addenbrooke's Hospital in Cambridge in the UK, and there, as part of their application for HIMSS accreditation, they actually did some reviews about really from the financial side. So by using SNOMED effectively, how much money they saved, how many lives they saved in various aspects. It's those kind of cases which, as SNOMED becomes more widely used and evaluated, those kind of, that information, those figures will become more prominent, I think, moving forward.
Yes.
Okay, so moving on, if there's a national terminology server, is it targeted just at the public or private or other clinics within Germany?
The Onserver?
Yes.
In fact, it started all with the HiMag project. We have a central instance and other instances. For example, in Lübeck, we have what is it called? Not a central instance. And so we are connected by syndicate mechanisms. And there are 2-3 other in Hanover and other places who are users of the Onserver, especially by using the API, the REST calls for validating codes for doing their projects as software developers. And our job is mainly to get all the Gecko and core data sets and value sets and ICDs and SNOMEDs and whatever onto server, and different versions and quality issues and transformation from left to right and using it, yes. But the guys in Cologne have to do the job to get the identity management and the authentication, so that only those who have paid money and have the right can get access.
And so keeping on the terminology server, does the terminology server that you use only support FHIR, or does it support other formats?
It's mainly support FHIR, but you can provide also comma delimited value formats, simple formats, and other transformation. For example, we have in German this CLAML format for ICD-10 and so on. Yeah. It can also be converted. There are some conversions available to import different formats of code system to the Onserver. But the primary level is to transform them to FHIR resources and to support the FHIR operations.
Okay. And there's one final question in the QA here, which I'm actually quite interested in some ways. So if you're not taking data direct from the AHR, but you're taking it from, in some ways, templates, so things that are filled in by clinicians after the event, how does that, or does it affect the reuse of data for other projects? So if you collect certain data for a specific project today, how does that affect that data being reused at a later date for something else?
Oh, I'm sorry, I did not.
It's not allowed to just use data. So if you don't have a consent form from the patient, you are not allowed to use the data. You can pseudonymize or anonymize data, but still, if you anonymize data, you can still not use the data. We are not allowed to use the data. So data has to be within the hospital. There's no cloud solution yet for Germany, and so we can just share or to have federated or sharing systems and algorithms that work on the data on the hospital, and we are not allowed to give our data away to like industry or pharmaceutical industry. So this is a problem. But I think your question was something different. It was about is it more easy if you have like the SNOMED codes in the very beginning, or structured data and technical. It's a technical question. Can we use it then in a better way or something? Yes, it should, but we are not allowed to.
Yeah, I just want to add to the first one from Sylvia. There are much progress actually at the moment going on to bring the algorithms to the data and not the data to the algorithms. That's the one point. There are fascinating approaches to have R scripts, for example, that calculate some figures in site 1 and site 2, and to get the aggregated results back and to aggregate them again. So there are a lot of stuff going on in that area. But the other point, I didn't understand it right, but maybe you mean, I call it early mapping, late mapping. If I get the data at the very beginning right, and the physician is responsible for data entry and so on, and not having his proprietary data getting to the data integration center and they make late mapping. Of course, late mapping is always the second best solution, of course. And there you lose a lot of information. Yes, of course, it's not good. We had the issue for a long time early before SNOMED came. We had the issue with LOINC, just to get the LOINC coding in the laboratories. We have in Germany not the LOINC in the laboratories. They have their own terms, and a lot of them are not able to map the local terms to LOINC. Okay, so we get their terms and we have to map. But it would be much, much better to have the specialists, the domain experts, at the very first place to do the mapping, of course. But what will you make?
Yes, I mean, what you're describing is the classic challenge in some ways. And you know, if you look at the Odyssey program, effectively they've done that by structuring the data in OMOP. So everybody has it in OMOP, and then whatever terminology you're using, you either map, I suppose you map up, if you like, you map up to SNOMED. So it's, at least you can have, then you have some way of making comparisons between data, irrespective of whatever terminology you're using at the time.
Yeah.
But I mean, you know, it is a challenge, definitely.
Yeah.
So we don't have any other questions in the Q&A box at the moment.
I put a couple of questions in the chat box because I'm not allowed to ask a question.
Oh, yeah, you can ask. You can always ask questions.
But not written ones. So, the couple of things I put in, which is some, again, rather general question, but I think one that's always of interest to all our audiences. If I understood your presentation correctly, the MI is basically made up of 24 academic medical centers. And my question is simply this, which is, in your teaching curriculum for medical students and indeed other healthcare professionals, do you teach the use of ontologies and SNOMED in particular to medical students? And would that make a difference?
Yeah, I think that this will make a difference and we should do it, but we didn't do it in the last 30 years. And we have 34, not 24 different universities.
Sorry, I got the wrong number.
Many students, and teach in the future. I will teach SNOMED CT as well, or right beside the ICD-10, and they know everything about ICD-10 because it is important for the DRG system, but they don't know anything about SNOMED CT. So first of all, I provide within the Charité, I provide the full SNOMED package to my students, and so they can try to work with it, or to map things, or to work. I think a very important part is the SNOMED within clinical trials as well. I don't know if you have a focus on this, but I think this is very, and PROMs. So if they are working with PROMs and clinical trials, they should use SNOMED codes to have precise documentation. So we are right now working on new programs for our medical students called digital health or something, and health data science, and so we will teach SNOMED, sure, and all these other terminologies too.
But it's really not easy to get it into the
curriculum,
the lectures and the curriculum of the medical students. But maybe we have another construction for the medical doctors, when they, at the end of their study, they can decide whether they want to make a medical doctor with a specializations in medical informatics.
Yes.
So a few of them decide, oh, that's attractive, I want to do it. And that is the one woman who works with us in the oncology topic. So it's maybe a few of them you can get and attract. They are interested, and they can learn SNOMED, and they are interested, and so that would help a little bit. Maybe both is important.
And is medical informatics then now an accredited specialty in Germany, as that you could, if you like, become a consultant in medical informatics or a specialist in medical informatics, or is it still on the edge?
It's still on the edge. It's a very specific idea in our university, but it's it's different from medical informatics as a computer scientist.
Yes, yes.
No, but there is a so-called Zusatzbezeichnung, additional designation or something. I have this. That's called medical informatics for doctors, and so you can. But there are just a few medical doctors who try to get the certificate.
Yes, but Silvia, that would be interesting to go into that topic maybe later.
Yeah, I just did this with the curriculum for the doctors. Yeah,
it's very difficult. Yeah.
To reassure you, most medical universities in again the United Kingdom do not teach medical informatics yet, and they won't make space in the curriculum.
We teach medical informatics every year, and we have quite good topics. But we should change some topics and to include SNOMED now. But it
hasn't happened yet. Yeah. I had one last final question, which is really thinking about incentives and frontline use of SNOMED by clinical professionals, which is the need to communicate in using structured terms between secondary care or hospitals and primary care physicians. And I certainly our systems now, we have to produce discharge summaries. I think it's fair to say that the discharge summaries to a large extent are still produced in free text, but increasingly they are populated with structured data from a problem list or a diagnosis list, which is almost universally in SNOMED CT. And there is a sort of, I think, a gold pot out there for making that data genuinely interoperable, so that a set of terms that have been generated in the hospital automatically populate the primary care record and vice versa. Is there anything like that beginning to happen in Germany?
Yeah, we have a different strategy. We have a discharge letter since 2015, and you get, if you're an outpatient doctor, you get 27 cents for each discharge letter, which is in our structured CDA template format. But you only have to use the header.
It's only the heading.
In the body, you have the medical information. The header is just about some.
Yeah, that's the problem with heading templates.
Yeah, the first step, and I think our next step will be like more or less file format for this. Yeah. And so, but they have to get money to do it with it. But I don't think that they should get money, because we only should have good software. If a vendor is able to give this template, the doctor, they don't care about line codes for sections in CDA. If you're just typing and if they give you a hint how to do it better and faster, they will do it.
Yes,
it's about the vendor and about the specification, and not something that you get incentives for, in my opinion.
Yeah, I agree with you, but it's hard to get the vendors to do that, isn't it?
Yeah.
Okay, we have one final question which has sneaked in under the wire. How is implementing the FAIR principles? Could that be used to accelerate the use of SNOMED in Germany?
Yes.
That's a nice easy one. As soon as I read that, very new, Sylvia, I actually thought that might be your response, purely by coincidence. Right, well, as we're at the top of the hour, much as I'm enjoying this conversation, I'm going to bring this session to an end. I was going to actually share my screen, but I've literally just had a new computer and the share settings aren't working correctly. So I will speak to what I was going to show you as opposed to showing you. So it's really just a bit of information for you. So you'll be aware that SNOMED has an annual expo. This year will be a virtual one. So unfortunately, we can't travel, although if we could, it would have been in Portugal this year. The registration for the expo opens on July the 15th. So no rush, tomorrow is fine. You can go to just snomedexpo.org is the URL, and please register. You can view the program and register at that site from tomorrow. So it just leaves it to me now to thank Sylvia, to thank Joseph, to thank Martin for trying to join on the train. But I'd like to thank all three presenters. I've found it interesting, and I'm sure you have. So thank you very much, and I'll bring this webinar to a close. And a round of applause from me. There you go.
Thank you.
So thank you, everyone.
Thank you. Very interesting.
Enjoyed it, and we'll see you next month.
Yeah.